morning, everybody. Welcome to day 2 of the Before I Die New Mexico Festival. Woohoo! Good day to be alive. So I'm Gail Rubin. I am the festival coordinator and the doyen of death. And so thankful to see all of you here in person. Thank you for all of you joining us online on Zoom. We will be recording these sessions and posting them to YouTube after the festival. So if you want to share what you've learned with other people, you can direct them to the Before I Die Festivals, plural.com website. And there's a page for videos, so you'll be able to access them there. In fact, you can access last year's videos now. They're already out there. Thank you to our sponsor, Bosque Trails Hospice, for hosting us here today. We are going to learn a lot about hospice today and all things related. I also want to thank our other sponsors who help make this festival possible. A good goodbye, that's me. Bernalillo County, their indigent program, Better Place for Us, Conscious Crossroads End of Life Services, Deaf Doula Danielle, and Deaf Doula Professionals, Brooke Nutting. End of Life Options New Mexico, thank you for the bagels and the coffee. French Funerals and Cremations, Keeper Memorials for the online access on Zoom, and Passages International, also longtime supporter of my work. The first hour and a half, we are talking about Hospice 101 and medical aid in dying. Our speakers are Dr. Rachel Rankin and Dr. Erin FitzGerald. Please come down. Take it away.
Good morning. Thank you for being here. Let us know if we need to speak up. We'll do our best. I am Rachel. I am the medical director here at Bosque Trails Hospice. I'm one of the part owners. I've been doing hospice for a while. And also some palliative medicine out in the community.
I'm Erin FitzGerald. I go by Fitz, and I'm also a hospice and palliative medicine doctor. I've been practicing in New Mexico for over a decade, and I've been working with Dr. Rankin here at hospice for almost a year.
One of the things when we were talking with each other about how to address this, these topics, one of the questions we had is who is going to be our audience? So we didn't know. And so one of the things we want to do is get a sense of who's here. So we're going to ask some questions and just raise your hand if it's applicable to you so we can get a sense. So who here is somehow associated with the medical profession? Okay. Who here is an interested community member? Okay. Who here didn't raise your hand?
Guilty. I'm from out of town though. So
Okay.
Okay, Taurus.
If you didn't raise your hand, what category do you belong to?
a visitor.
Visitor?
I'm the volunteer coordinator at a hospice in Las Cruces.
Oh,
So I'm not.
okay, that's fair.
Visitor.
Anybody else?
That's
Danielle?
doulas. So we're not medical, but we're adjacent.
But you support the community.
Okay.
So
We support.
familiar with hospice in the community.
Okay.
Okay.
And who's had experience with hospice? That's a lot of us.
Before we start talking, I was hoping some people could just sort of shout out things you're hoping to learn or hear from us so we don't miss those things.
What do you do in this building?
This building, okay. What else? Yeah, the question is. Is that working? Okay. The question is, what do you hope to hear from us today before we start talking so it's in the back of our minds and we don't miss it?
And the first question was, what do we do in this building?
Do people sleep here? We will address that.
Why are there so many providers and how do you choose one?
How do you pick a hospice agency? Good question. What else?
For profit versus not-for-profit.
For-profit versus non-for-profit. Got it.
When a patient wants to access MAID, what are the steps, the logistic decision, and then who do you see and how do you get that?
How does a patient access MAID?
How do death doulas get started here in New Mexico, and what kind of training is available?
That's a great question. And actually, we will have a guest sponsor to answer that question in a minute. How do death doulas get going? Okay.
Where is MAID legal and not legal in the United States?
Which states and jurisdictions have medical aid in dying in our country?
This is good to get a roadmap, to know what people want to know. It's very unhelpful if we're talking about something that is like very basic to all of you. So this is very helpful. Are there more? Oh yeah, there's more.
What can you utilize if you can't access MAID?
What alternatives are there if you don't qualify for MAID? Good question.
What's the role of the volunteer in hospice?
What do volunteers do for hospice?
Great question.
There can be more questions, just jump in, but I think we're gonna start with hospice. What is it? How do we do it? How do you pick one? What do volunteers do?
What is this office for?
You can do the office. This office is basically our administrative office. It is also the beating heart of our team in that it is very much a piece of our culture where we gather to do some work and have some lunch and share stories as we're gathering supplies and checking in with our team. But no patient care happens in this office. The rest of the building is an assisted living facility right now, but that's separate from us.
Sure. Hospice is,
Use the microphone.
hospice is a very confusing, word because it means a lot of different things. It is a healthcare benefit. It's a Medicare benefit, which is what a lot of people think of when they think of the word hospice. They think of insurance. There's no other place in medicine where we do that, where we say cardiology, and that also means the insurer and how it's covered and what it's covered. So it's really a hard concept to think about. So hospice is a Medicare benefit. It is also a philosophy of care and a specialty of medicine. And so when we talk about hospice, we know we have to deal with Medicare and somebody bless them, but that's not what we're really talking about today. We really want to get across what is the philosophy of hospice, why do people come to us, when do they come to us, what are sort of the nuts and bolts of what we provide to folks out in the community. And then there's all the nitpicky Medicare stuff that if anybody has questions about, we can absolutely answer them, but it's boring and kind of off topic. So hospice is a philosophy of care that really prioritizes comfort and quality of life at the end of a person's life, taking into account all of the people who are part of their community. And it really offers support to the dying person and to the people who love and care for the dying person. It is a holistic type of care in that we use multiple disciplines. Physicians, nurses are the big bosses, which we love. Chaplains, social workers, volunteers, bereavement coordinators, home health aides, sometimes physical and speech therapists, to really do a good wraparound care for folks who we believe have 6 months to live. Neither Dr. Rankin nor I have crystal balls, and we in medicine are not very good at prognostication, to be honest with you. If you look at all providers who look at a human being and decide what their prognosis is, we overestimate by a factor of 5. Overestimate their prognosis. So if someone has a prognosis of 1 month, we believe they have 5 months. If someone has 1 year, we believe they have 5 years. So we're not very good at it in medicine. And one of the,
Inflate?
what's that?
Why do you inflate?
Because we are humans who like to see the best in other humans. And the longer our relationship with the patient, the worse we are. Because the more of the subjective things about our relationship with each other. So all that to normalize, it is very normal for people to come on to hospice. And then they actually get a little better and we think, oh dear, maybe they weren't dying after all. Or they come onto hospice really late, which is actually more common. They get referred very, very late, within the last weeks rather than months of life. And the whole goal of hospice is to help people live as well as they can, for as long as they can, in the place that they call home. So we really want to help people live well, and also dying well is a byproduct of that. So living well, sucking the marrow out of your every last day on planet Earth, being comfortable, being able to spend the time that you want to spend with the people you want to spend, usually away from the hospital, because that's not where most humans want to die. So that's kind of the philosophy of hospice, which is very, very important to both understand and to think about when you're considering whether it's for you or for your loved ones, whether hospice is really right for you. It's really quality of life for the short time that we have on planet Earth. I'll pause there.
Do you have any inpatient hospice units here in Albuquerque?
Yes, but not many. So Presbyterian Caseman has 10 beds inpatient for our general population, and the VA has a small number of beds for the veterans. And right now, that's what we have in terms of facilities that were actually made to do GIP, general inpatient hospice, which is a level of hospice to be used for a very short period of time to get uncontrolled symptoms controlled, to then return to that place where you were living to continue your living until you die. But it's not intended to be long-term. Good question. Other questions before I address some of the previous ones?
Hospice is not a place, which is a really common misconception. In Spanish, the word hospicio is a place. It's a physical place. For the definition is for the destitute, which I hate that word. But in this country, hospice is, like I said, a benefit and a philosophy of care. And it happens where people call home. Most of the time that's home, in their own home, apartment. But that can also be in a nursing home or in an assisted living, or in the case of someone who might be living on the streets, it might be on the streets, but it is in the place that we call home. So it's not a physical place.
You talked about the difficulty in estimating. So I know the definition is 6 months or less. So what happens if the 6 months is up? I've heard horror stories of people saying they just boot it out. That's not been my experience. How do you decide?
Great question.
Great question.
Can you summarize?
Yeah. So when we bring somebody onto hospice, we,
Summarize the question.
oh, sorry. The question is, what happens if you live longer than 6 months? Do you just get kicked off? And the answer is, dear God, I hope not. Certainly, we've heard those stories. We have to prove to Medicare that somebody meets criteria when they come to us. And then we periodically have to re-prove to Medicare that somebody meets criteria. And even if somebody is living longer than 6 months, but they continue to meet criteria, which has a lot of things in there, and we won't go into that. As long as we're continuing to prove to Medicare that that person meets criteria, we can keep them on. But if we start noticing, wow, we got this person home from the hospital and they looked like they were gonna die, but then they got home and they got to snuggle their cat and they got to see their loved ones and they got to eat their favorite food, and wow, oh my gosh.
Sleep. They got to sleep. That happened. That doesn't happen in the hospital.
They didn't get interrupted 70 million times every night. And now they're getting better because that happens. And we're thinking, gosh, I don't know that we can prove to Medicare that they continue to meet criteria. We as a team start having a conversation with ourselves, with the patient, with their doctors from before, and we come up with a plan so that they can have a safe discharge back to the community. We cannot discharge somebody if there is not a safe discharge, if there is not a plan for them to be followed, if there is not somebody to prescribe them those medications. That's not okay. And then we're here to welcome them back should they decline again. So in our hospice, that's how it works. If we can't find a safe discharge plan and they don't meet criteria, then what we would do is flip them to a pro bono status and continue to care for them until we could find somebody.
Thank you.
Yeah, good question.
No whole hospices will do that.
Correct. So
So, yeah.
some of what you're hearing here is how we do, how we do hospice. That is gonna be different than how other people do hospice, and so it's a little bit of a biased look because it is different, and we'll talk about how do you pick in a little bit.
And I just wanted to speak to, it's much more common for folks to hit that 6-month mark and continue to show decline. People don't die like the textbooks tell us they're gonna die. And we know that once people are home and living well, they actually do live longer. So we have studies that show that for certain populations, heart failure, certain cancers, folks live longer with hospice because they're staying out of the hospital and they're with their humans and their pets and their bed and their comfort of their own home. And so it's much more likely that we come up on that 6-month mark and Medicare says, oh, they're not dead yet. Now what? And we say, that's okay. They're still declining and they're still in their final months of life. And we have to do a lot of work on our end to prove it. And there's a lot of reassurance that happens with families because families get very nervous about being discharged. Once you get the warm fuzzies of the 3 times a week, 4 times a week visits from various members of the team, you do not want to let that go. Yeah.
Take care of non-Medicare patients or younger patients also.
Great
with
question.
insurance?
Please repeat.
Do we take care of people who don't have Medicare? People who are younger, people who have different insurances, people who have no insurance, and the answer is yes. There is occasionally a patient, getting contracted with insurance companies is complicated. I would like to say that, in general, we take care of everybody almost regardless. And very occasionally do we have to say no to a patient, in which case we'd find them another place. But yeah, we take most insurance companies and younger patients, of course.
That includes people on Medicaid?
Yes. Medicaid, private insurance, Medicare. Pro bono.
It's so confusing because it started in the 80s as like just a Medicare benefit and it is like grown from there. And so it's a little bit confusing. Medicare is sort of the gold standard that we talk about when we talk about having to meet certain criteria. But yeah, basically any human who is within, we think, their last 6 months of life, we're going to do our very best to get them hospice somehow, regardless of their insurance status.
So I want to talk a little bit about volunteers. What do volunteers do? Volunteers come in with a variety of backgrounds and interests and reasons why they came to volunteer with us. And so typically we try to figure out, hey, so what brought you to volunteer with us and what do you have to offer? And how can we pair you with a person or loved ones who are going through this journey in a way that is supportive? So sometimes it's sitting with somebody so that their loved one can run to the grocery store or go to a yoga class. Sometimes it's reading to people. We've had musicians come in and play music for people. It's pretty varied. And so each volunteer brings their own unique wants, desires, and things that they're great at. And we just try to incorporate that.
And if you have a therapy pet, we want you.
Did that answer your question? Forget who asked about volunteers. They're wonderful. They can be an incredibly integral part of a patient and their loved one's life and journey. We always joke that somebody on the interdisciplinary team, which is all of us, ends up being the primary person, and the volunteer sometimes can be that primary person for sure. And
How about the difference between nonprofit and for-profit?
well, so I'm biased. We are a for-profit organization. because we were small and limited in funds, and becoming a nonprofit is hard. There is a difference. It's mostly a tax difference and a difference for donations. I would argue that although we're for profit, we are very much, our mission is very clearly nonprofit in the sense that we want to take care of our community in a way that makes sense to us. We want to educate our community, both medically and community wise. We lift up other small small hospices in the community because that's what we want to see grow. So I think it matters more who the people are and what's important to them, and do their actions show what their philosophy is, or is it just written on a piece of paper and they don't actually walk the walk? Is I think what I would say.
So are you seeing, so I'm fairly new to New Mexico, less than 2 years, I came from Chicago, where the hospices were getting consolidated and bought up by the hospitals. Are you seeing that there? And to me, that also showed a decline in personal touch.
How long do you have? Yeah, we are seeing a huge turnover towards corporate entities buying out small hospices. That's why we started. We saw that happening and didn't want to do medicine that way, where corners were being cut. It wasn't as much about the humans and their loved ones. We were told how we could do it. So yeah, we have a ton of corporate hospice in Albuquerque and not as much small, local, community-owned hospice. And so part of our mission statement is to elevate what hospice truly is and can be. And I think we're a story where it works. We were able to do it. We were able to show our community that you can do it excellently and make payroll, right? Like you can do it in a way where you support the unique needs of each patient, sometimes expensively, and still have success and do what you set out to do. So there's a huge difference, and yes, Albuquerque is quite corporate, unfortunately. Yeah, we just wanted a company where our employees matter as much as our patients matter, as much as how we do the medicine. And when you do it that way, we're proof that the community listened, they noticed, they have supported us, we have grown. We are now the site to teach fellows from UNM how to do this kind of medicine. So, so that piece of our mission statement, which when we sat down to write it and felt so important to us, which was educating our community, all of the kinds of community, it's coming to pass. And so that it feels great. So thank you for being here.
How old are you?
Well, to be asked women, how old are you?
You're almost 2 years.
We're almost 2 years old. We passed our survey in March of 2023. So in March, we'll be 2 years old.
I think this is a good time to talk about how on earth, when you see the list of, what is it, 30 something, how many hospices in Albuquerque? 20 something hospices, how on earth do you choose? I am not an owner of this business, so I'm going to answer that, and I want to hear what Rachel says. There's Medicare ratings. They lag a little bit. So the good old Google is a great place to go. Word of mouth, I think, is really important. I think when folks have bad experiences on hospice, they tell people, and not as often, but still often, when they have good experiences on hospice, they tell people. So I think it's important to take recommendations from the community. If I were to be choosing a hospice for my loved one of the very first questions I would ask would be, is the physician willing to come to the home and see the patient? You can weed out a lot of hospices that way. And I think that's really important. Not every person at the end of their life needs a physician visit nor wants a physician visit, and that's okay. The nurses are the primary team member and they do a phenomenal job. The nurses are amazing.
Even in the clinic.
Even in the clinic. And it's important that if someone's symptoms are out of control, or their family members aren't all on board with hospice, or there's existential suffering, or there's you name it, that will be available, that a physician will come to the home and see the patient. So I think that's a really good screening question. I think it's also an important question to ask, where is the hospice? like, there's a lot of hospices in Albuquerque right now whose hospices are out of state, whose physicians are out of state. So it might be a doctor and a hospice company in Arizona with a couple of satellite locations here. But there's no physician here who is gonna come out in an emergency. There's no one physically in the state. So I think that's another important question. Where is the hospice? Those are my my three. The recommendations of the community is huge. Will the physician come out and where is the hospice center?
And I would just put out there, which is a little bit of a tangent, but if a hospice isn't a good fit, you can switch. Right? So it is freedom of choice. It is not a one-way road. Patients can both choose a different hospice or decide they want to take a break from hospice, right? So I think it's important that, you know, I think you're probably all aware of all of the things in the press right now about hospice and fraud and all of the bad things that happen. And you can get away from that if you need to switch. You able to come off hospice, go back on hospice, and are you less likely to be able to get back on hospice if you've done that? Good question. You can revoke, that's what it's called, you come off hospice. Most of the time you come right back on. There are probably times if somebody does that too many times, a hospice might get a little skittish because we truly want to care for people at home. And if they're really not ready, then we would rather that person go do the things they need to do medically and then come back to us. But yeah, absolutely, you can come off hospice and come back on.
What's your service area?
Our service area goes down to Belen, all of Rio Rancho, up to Algodones, east to Moriarty. Wow. And then south to Belen. Yeah, that's big. Yeah, it just sort of happened. Yeah. Medicare Advantage. Oh, sorry. If you have a Medicare Advantage plan, can you just choose your hospice? You can always just choose your hospice. You can always call them and self-refer. It is your choice. This is your body, your life. You get to choose.
So it was kind of touched on earlier, but could you talk a bit about residential hospice? I actually live in Portland, Oregon. We have a population of about 650,000, and we have one residential hospice in that city with 14 beds. And the need far outstrips what's available. Just wonder if you could touch on that.
Residential hospice. Who knows what that is? We don't have it here in Albuquerque, really. Residential hospice is somewhere where you can go and receive your regular old hospice care there, as if it was your home. We have, Press has one that I don't know a ton about. I feel like it's had some stops and some starts. There's another one starting downtown that's gonna have 3 beds. Where
We just toured it.
We just toured it the other day. There's a huge need. There's a huge need because the number of people who can't or don't want to die at home is huge. And what is their other option? They have to look at assisted living or nursing facilities. We all know why people might not want to do that. Where I trained in Denver, there was a number of residential hospice houses where people could go and receive whatever level of hospice they needed. We don't really have a whole lot of that here. So it does sound like the community is aware and we're seeing a little bit more of that, but not a lot of those beds exist.
You cover a pretty wide area. What does your volunteer base look like? How many volunteers?
How many volunteers do we have right now? And the answer is about 20. We would love more.
Therapy vets, hairdressers, nail people, what else? What's on our wish list?
And follow-up?
Massage.
Yeah, looking at the demographic in this room, and I'm gonna retire in a few years and I'm on a journey to be a vet caregiver. It fascinates me that it's mostly women volunteering to work in this area. Any thoughts about why that is? No, it's just curious.
Yeah. The question was, how come it seems like there are more women who volunteer or maybe are in hospice in general? And I think the crowd answered it.
Yeah.
I think you might be an exception to the rule.
I'm gonna be really bold too, given my husband and brothers. I think that men experience and or process their mortality differently. Women
Sure.
give birth,
Sure.
and there's a precariousness of giving the birth that the baby survives, they
Yeah.
survive. So they've already brushed up against that,
Right.
and then by default. But I do think men allow that default because they
Right.
don't always want to step in because it's fearful.
Right. And I know all of these answers, but I wanted like a reason for that. What we can do as nurturers to make it a more broad, right? I think it's a valid point. I think it's a valid call to action to get everybody in the community involved in life and death, right? That was-
Thank you. Good point. I would love to see more of that.
Hormone replacement.
Some of our most active volunteers actually are men right now.
Cool. Good.
How many patients can you serve?
I would like to say as many as need us. We've had a few periods of insane growth where we have stretched to meet that need, but we try not to say no, and our team is so gracious when we're in those periods. Right now, we're not as stretched, and so they have a little bit of breathing room, and so we like to think that they know that there are big periods and little periods, and they are at the core of what's important to us, and so I think we do our very best to take care of them so that when we do grow quickly, we can meet those needs and then catch up with
So
staffing.
how many do you have right now?
119.
119,
Wow.
yeah.
Since organizations can opt out of participating in medical aid in dying, wouldn't that be another criteria also that a hospice is willing to handle MAID versus perhaps a faith-based organization that would be anti-MAID?
That's such a great question. I'll repeat it, but what a seamless transition from one topic to the next. And I didn't even ask for that. So thank you. The question was, what about MAID? Isn't that a good criteria for choosing a hospice if there's hospices who are not participating? And there's a lot of hospices who aren't participating. Whether they're not participating in that the physician is not prescribing and the support team will still be there on the day of death. Or some people are completely opting out and saying, no, we're not participating in MAID, and if our patient chooses to do this, none of our staff members are allowed to be present on the day of death. So there's a spectrum of what not participating looks like, just to say that out loud. That's really important. For folks who are dying and have been on hospice, to take their stable team that's been caring for them for maybe months, maybe even years. We do have people on hospice for years because they don't read the textbooks. So that's a very important question. Will the nurse who's been caring for me for 1 year be allowed to be here on the day of my death and support me through this? So that is a wonderful question to ask on admission to hospice, if that's something that someone is interested in, if MAID is a possibility for them in the future. I feel like there was a second part to the question that I just lost the thread of.
There's a lot there. Before we continue with this, I want to make sure, does everybody in the room know what MAID is? What do we mean when we say MAID? Medical aid in dying. Everybody knows that New Mexico has this law, that it's a way to peacefully end your life by ingesting a combination of medications of your choosing. You do it. I see your question. I just want to address what other states. There are 11 states and jurisdictions in the country that have it. I don't know that I'm going to be able to list all of them, but of course, Oregon was first, Washington, Vermont, Montana, Colorado, New Jersey, Washington, DC, California, New Mexico, Hawaii, and we're missing one.
Colorado?
I said Colorado. Is Virginia?
No. I think maybe Indiana, but I'm not sure.
No.
New York or New Mexico?
We got one more.
Well, there's one more.
Minnesota?
Oh, Maine, yes. you
Oh,
are
my
correct.
home state, how could we forget? Don't tell on me. Oh my God.
So those are the 11 states and jurisdictions. We know what MAID is, so everybody understands. And then you had a question.
What is your participation?
Excellent question. We fully participate in medical aid in dying. Dr. FitzGerald and I both write prescriptions, evaluate for, and almost always attend the deaths of patients who choose to participate in MAID. I think this is a really good place to say that while there is a lot of excitement around the availability of medical aid in dying in this community, and there should be, and we fully believe in it and that it should be accessible to everybody, it is but one piece, one tool in our toolkit of excellent hospice care. So while somebody may say to our admissions nurse or at discharge from the hospital or whenever, I'm interested in MAID, we're very happy to know that. We will always default to making sure that we're doing excellent hospice medicine first. So if somebody is in crisis in any way, whether it's symptomatically, existentially, and they're grasping for MAID as the answer to that, we will note that and do our very best hospice medicine first. So what it means is that MAID is never an emergency for us. We do not rush to see those patients ahead of the patients who are on our list to be seen. If they're in a symptom crisis, we will address it the way we do any symptom crisis, because we don't want people making those life and death decisions. That's a big decision when their brain isn't actually working well because they're in severe pain or spiritual distress or existential distress. And so the way we practice medical aid in dying is as a complete standard of care. It is a before, a during, and an after. And it is partly why we feel so strongly that people who are going through medical aid and dying have the support of the hospice IDG team. Ideally for long enough that they know us and we know them, so that when stuff comes up, and it does, we feel safe to come to for support. And so we may ask for a little more time with people while we're either dealing with symptoms or getting to know them, and that's why.
You said IDG a couple of times, so what is that?
IDG, sorry, you are correct. Interdisciplinary group is what we call the team of human beings who care for the patient and their loved ones. So it is our nurses, our social workers, our spiritual counselors, our CNAs, so our home health aides, the physician, everybody, the volunteer, everybody who is in that pod caring for that person is called the IDG, and we lean on all of them. And for medical aid in dying, we've actually recently changed to making it mandatory that people allow the entire IDG in at least a little for support, because we need it as much as the patients and their families need it, because it is a really big deal.
And one thing just to add to that is the importance of the after. So when we have seen in these 3 years of MAID being legal in New Mexico, that when people quickly rush to MAID and quickly make the decision and maybe even ingest and die in a period of crisis, their survivors are now in crisis and will be in crisis with complicated grief, PTSD, anxiety. So we're not just taking care of the human who wants to ingest MAID, we're also taking care of their families. And the survivors are very important. So we really, that's why we don't force social work and spiritual counselors on hospice patients. They can opt out, but when they want to choose this, we need the whole team to care for the whole family before, during, and after. It's super important. And because this is so new, and because Dr. Rankin and I are in a really unique position of being hospice and palliative specialty trained, fellowship trained, we get to help develop the standard of care around this. And I think it's really important that we do it well, and we have to be able to sleep at night.
I just want to say that grief counseling, bereavement support can continues for all patients.
Thank you.
And their survivors.
Yeah, bereavement. So Victoria's making an awesome point. So it is a Medicare benefit to continue to receive bereavement support and counseling for 13 months after death. We will do it forever, anytime you need it. Also know that if you have a loved one who dies not on hospice, all hospices should accept you for bereavement should you need it.
First of all, I'm super grateful that in Mexico, we now have a choice with regards to medical aid in dying. The thing I'm curious from your perspective, if you've seen any advancements on the horizon that might make it more like in contrast to, if I have to put a pet down, it's really simple, less than a minute. Pet isn't suffering at all in contrast to the cocktail we have to take and the amount of time it can take, the fact that we have to have sorbet to cool down our throat. Because just, have you seen anything coming that way? That's a tough question.
Yes, there are a lot of people in our country who feel that we should be able to do this injection, which is euthanasia, which is illegal in our entire country. And so, yeah, there are a lot of people fighting that for very many reasons, because the next question that's going to come up is, but this isn't accessible to all populations.
Right.
What about our dementia patients? What
Right.
about our ALS? What about? So our current status in our country is not perfect.
Right. Well, and my question isn't so much an alternative, but an improvement on the way we're doing it. So that it falls within the regulations and the laws and all that stuff. But the human doesn't have to suffer so much.
Yeah, I hear you.
Yeah. I'm just hopeful that.
So the American Academy of Medical Aid and Dying, which is renaming
changed the
their
name.
name, and I don't remember what it is. They collect data and they are constantly reviewing it to improve our cocktail. The current one we have has the shortest average time to death nationally.
It's getting better.
It's
Yeah.
getting better. So
Yeah.
if you look over the last 10 or 15 years, our average time to death is shorter. The suffering, as you say, has decreased. Although I would say with this new cocktail, they added phenobarb at time of all the other medicines, and patients go into a coma within minutes.
Yes.
And I don't believe that they're suffering.
Right.
It can be hard on the family when the death is long, for sure, but we counsel on that.
Yes.
Would it be easier if it just worked like that? Yeah. Also, have I seen a number of amazing deaths where they take those 2 hours to sing songs and tell stories?
Yeah.
So I think that the idea is always to make sure that the medicines we're using are as smooth and quick as possible. And that institute, what do you call it, that organization is always collecting data. They have pharmacists on board, and so yeah, they're always looking to make it better.
Okay.
I don't know that it will change from medicines absorbed by the GI tract.
Yeah. Why
Anytime
isn't it a
soon.
capsule or something instead of?
Absorption.
Oh, got it.
We want it
I
to
knew there was science.
get absorbed.
Yeah. Okay, cool.
You,
I'm gonna let Danielle just.
Yeah. I'm just wondering if it might be helpful if you explain the process. Because not everybody has seen it, don't know what ingestion looks like, and maybe the suffering that you're referring to of the taste of the medicine specifically and the burning.
Burning, yeah.
Sure. Is that okay with everybody?
Not everyone wants to hear that. And also it might be helpful to hear from the moment that maybe I say I'm interested in MAID, now what? So is that helpful? Okay. Okay. So if you're in an outpatient setting, I actually just asked this question to the folks at UNM who have a palliative care clinic, and they evaluate folks for MAID. So which is not a small thing. So the first and most important thing that I think I would love for everyone to hear is that we get to be wrong about prognosis for hospice, right? Folks come onto hospice from the hospital, maybe they look like they're really close to death. They've just been in the hospital, serious illness, and we think they're appropriate. We think their time is less than 6 months, and we take care of them for a few months, and lo and behold, they get better. And we say, no harm, no foul. Here you are, you got better. You're no longer at the end of your life. Congratulations, you've graduated. We'll see you when you're dying next time. I mean, I'm kind of joking, but also we have a lot of humility that we do not have crystal balls. And even though we're end of life specialists, we get it wrong. We really do get it wrong. We cannot get it wrong with prognostication with MAID. There is a much higher bar. So if I take care of someone on hospice and I'm like, oh, you know, you might be graduating next month, and they ask me for MAID, I have to think long and hard if they qualify. Okay, so that bar is much, much higher. We have to be very certain about prognosis. So that's the first thing. The second thing is if you're in an outpatient setting, you will get referred to a clinic, and the wait time between asking, I would like to be evaluated for MAID, and actually getting into the clinic is at best 2 weeks, 1 to 2 weeks. I've heard 1 week, but it only happened a couple of times. So I'm going to put that as an outlier. That's at best in Albuquerque. That is not the case for the rest of the state of New Mexico. So not everybody is evaluating for medical aid in dying. There are not clinic supports set up. None of this infrastructure was here when the law became legal. So it might take several weeks to months for a human being who's interested in MAID to have a consult to see if they qualify. There have to be 2 providers. They do not have to be physicians, PAs, NPs, physicians. 2 providers have to say, yes, this person's prognosis is less than 6 months. No, there is no financial coercion. No, there is no issues with decisional capacity. This human being is able to make their own decision about this. No, there is no symptom crisis. No, there is no physiologic reason why this person wouldn't be able to take medical aid in dying. So there's a lot of areas where you have to say yes, yes, yes. Then once someone becomes, let's say I go to clinic, I'm seen in clinic, 2 physicians say that I'm dying, 2 physicians say that my mind is working, nobody's coercing me, I'm not in a crisis. I'm missing something. Those are the big things. Then they can say they're going to write me a prescription. There is a 48-hour wait time in New Mexico between the writing of the prescription and the filling of the prescription. That's what the law says. It's a little loose. It can be waived in extenuating circumstances. I've had it waived one time because of an administrative issue. I sent the prescription, the pharmacy received the prescription, something happened at the pharmacy, they lost it, they didn't make it, I called them back and I needed it tomorrow. We waived the 48-hour wait, but that was an administrative thing. Can you think of other reasons why we've had to do that?
That part of the law is really meant for if all of a sudden somebody's taking an acute turn, they really want to make use of MAID and you're worried they won't make it, then you can waive it. I would say in that situation, just make sure your capacity is still there.
That's great. So if their physical decline is extremely sharp and you worry they're not going to be able to swallow in 2 days, but their mind is still working. Is there a question?
Well, since we were kind of at that point, I wanted to talk about capacity. So let's say you've had a cognitive assessment, like a SLUMS or an MMSE, right? And you have a diagnosis of cognitive impairment, but not dementia. If you have a diagnosis of cognitive impairment based on the cognitive testing, are you considered of limited capacity? So would you not be able to request medical aid in dying?
Great question. If testing has shown that there's some cognitive impairment, but you don't have a diagnosis of dementia, can you still make use of MAID? It is a case-by-case basis. I'm going to be sitting across from this person having an informed consent discussion. If they can't tell me what's going to happen when they drink the cocktail, no. So we go down the same process that we go down for any big procedure or surgery. It's informed consent, risk benefits. The human who wants to use the medical aid in dying has to demonstrate that they understand the repercussions, they know what the alternatives are. It's a pretty high bar. If there's mild cognitive impairment, someone might not be able to have that level of insight or executive way down the line thinking. But some of these cognitive diseases are very surprising. They affect maybe personality, but not thinking. They affect maybe physical, abilities and weakness, but not thinking. And so it really is patient dependent. I wouldn't say no to someone just based on the diagnosis they have in their chart. By the way, it's real popular to give someone a diagnosis of dementia in the hospital when they're acutely delirious and will get out of that. So I often don't trust dementia until I've had the conversation myself.
I'm curious about the two providers and maybe at the same agency because they need to be from different. And if the patient is on hospice, can it be two of the hospice doctors?
Yes.
But they're not having to drive all over town to get two
Correct.
completely unrelated.
Two people can work at the same institution. If the person is on hospice, yes, it can be me and Dr. Rankin. It can be me and Elizabeth. It can be me and the physician who referred the person to hospice. We try not to, especially in New Mexico, where we have a paucity of providers, we try not to make it extra hard for people. But it is tricky in some rural areas to get two people to say that the prognosis is less than 6 months. They might have to phone a friend. And that's actually appropriate. You can phone a friend. You can pick up, I could be the provider in the rural community. I could pick up the phone and call the doc who's 30 miles away and present the case, and they could say, yeah, I agree that the prognosis is less than 6 months.
Without seeing the face to face.
If we take on that, so we would do that. Not everybody's willing to spend that time, but yes, the provider can do a provider to provider call.
Has to be a physician or a PA or something along those lines.
Physician, PA, NP.
Irrespective.
Yep.
What's the history of what you give them? You know, Marvitol, what else do you give?
Amitriptyline. So this is a question about the medications, which I'll answer quickly, and then we'll go back to the process. Digoxin, amitriptyline, morphine, phenobarb, diazepam. In quantities that are staggering.
When you say prognosis, does that take into account quality of life?
That's a really good question. When you say prognosis, does that take into account quality of life? Unfortunately, it doesn't. And that's one area which we've probably all had a little bit of experience with. There are people who are excluded from even being able to consider MAID just by their diagnosis alone. So dementia, when you get to the stage in which you have less than 6 months, I will never say never, but almost never is your mind working well enough to make that decision.
It's on in a neighboring state that doesn't have the MAID law, Arizona, can you also clarify the criteria for residency?
Yeah, so you have to be residing in New Mexico. That doesn't mean you have to have a New Mexico license or even a piece of mail with your New Mexico address on it. You just have to be here. Physically here. Yep, you gotta be here. So we have had some people who have moved from other states. They might have loose connections, family, friends, or whatever, and they come and live at their friend's house, and then they get evaluated for MAID and they go through the process when they're here. It's not very strict. Our law is loose compared to other laws. On purpose, because there's a lot of things that we can't take into account when we're writing a black and white law that it's just hard to think about.
You also die here.
You have to die here. That's right. You cannot take the medicine and go to Texas. Please don't take the medicine. I don't want my name on that bottle in Texas. So, just kidding.
My question is related to volunteering, because I'm considering that. Are volunteers involved in MAID as far as being present at times? And secondly, what are the qualities of an effective volunteer in hospice? What qualities do you look for?
So 2 questions. Can a volunteer participate in the process of medical aid in dying? And what are effective qualities of volunteers? The first one is, again, case by case basis. If somebody is a volunteer and super connected to that patient and family, and all parties involved want to be there, it's fine for us, right? In our agency, we believe that the people who are important can be there. Effective qualities of a volunteer, I mean, in my mind, somebody who wants to be here and wants to do the things with the people who are going on the journey. Victoria, anything you would add?
I would just say part of service and compassion and willingness to be flexible.
A heart of passion, service, compassion, and willingness to be flexible.
And is there much traveling involved for the volunteers?
I mean, driving to the homes, wherever the homes are.
It's a big territory.
And it's a big area, yeah.
Well, I just wanted to point out, because I've done volunteer work with hospice in Oregon. My background is in marketing, event planning, and PR. So those are the areas that I volunteered in. I actually have, very little patient contact. So there are different skill sets that depending, especially with nonprofit hospices, that are really dependent on, on volunteers. So you can participate and support your local hospice in other ways that doesn't require patient contact.
That's a great point.
Yeah, thank you.
We do have volunteers who are in charge of addressing our condolence cards. Sometimes making phone calls to patients. So your point is there's some administrative stuff that you could do as a volunteer that is incredibly helpful for the hospice.
Is MAID available for people who are incarcerated?
Oh.
Is medical aid and dying available for those who are incarcerated?
So here's one really important, I think, positive thing to know about people who are incarcerated. They are the only group of people protected by the Constitution with a right to health care. And it's a federal, prisons are federal, so absolutely not. And so far, we have to look into the MDC, but thus far, no, they are not able to access medical aid and dying.
There's some hospice, there's some hospice programs and some, especially in California.
Yeah.
So I thought maybe within those hospice programs, they might.
There are hospice programs within some of the jails and prisons in other states. We don't have that in our state, unfortunately. Our end of life care, that was a specific population of people I worked with at UNM a lot, and we've done a lot in Albuquerque to improve the in-hospital care of folks who are incarcerated. We've done a lot. We've come a long way. We've gotten lots of people compassionate release. If we get compassionate release, they would maybe be a candidate for MAID. But that's something we can basically beg the judicial system for when someone is at or near the end of life who is incarcerated. And we've done that successfully, but thus far no MAID in prisons or jails. Or the VA.
But they can transfer out of the VA and hospice to like your hospice then?
So can veterans, great question. Can veterans use medical aid and dying? I just want to pull the audience first.
Yes, but not.
Not at a VA. Yes, they can, because they're citizens of New Mexico. No, they cannot get it through the VA. So we take care of a lot of veterans on our hospice. We love taking care of veterans. We work really closely with the VA. Let's say the person's on our hospice, either Dr. Rankin or I would be the prescriber for medical aid and dying. None of their VA providers would be involved whatsoever. It does not go on the death certificate that someone used medical aid and dying. Their terminal diagnosis is the cause of death. So if someone has cancer and they ingest MAID, cause of death is cancer. It also does not take away their veterans benefits. That's another thing veterans really worry about. If I use MAID, I'm doing something that's illegal according to the VA, and they're not going to give my survivors the benefits. That is not true.
What about life insurance?
Great question. Cause of death is the terminal diagnosis, so it does not affect life insurance.
Is there any insurance company that will pay for the cocktail? And what is the out-of-pocket cost to the patient?
Great question. Insurance companies, Medicaid in New Mexico.
Wow.
Not in all the other 10 jurisdictions. Medicaid has started covering. That's the only one that we know of. The out-of-pocket cost is $550. There are ways to get that ways to get support for that for folks who can't afford it. I think through end of life options in Mexico. Okay.
End of life options New Mexico can pay for the medication. Also Contigo, our compounding pharmacy, has on occasion given us the medications.
So if the
Yeah, I saw that.
is listed as whatever the diagnosis is, do we have records? Are we able to track how many people are getting this and what the need is? And
Good question. Yes, we physicians fill out, or whoever prescribes, we providers fill out a form after every death that is submitted to DOH. It doesn't have as much information on it that I wish it had. It has sex, age, did they self-ingest, ethnicity. There's a whole lot of data I wish we were collecting because our New Mexico population, and we have not gotten into this yet today, but is very different than all of the other states and jurisdictions, right? We are a minority majority state. We have some cultures in whom talking about death and dying is incredibly delicate and very different from direct conversation. So yes, we are tracking some data. End of life options New Mexico is also tracking deaths. But yeah, so sort of.
So we have an online question, comment. Person said, I asked my oncologist if he would write a MAID if needed. He said yes, that he would, but the hospital he worked with would not allow him.
Right.
Want to comment about that?
So he could lose his privileges?
I'm not sure
Yeah.
if maybe that commenter wants to add to their comment what they mean. That they wouldn't allow the doctor to work with the hospital with medical aid and dying was involved.
Yeah, so correct me if somebody knows more than I do, but an organization is allowed to opt out and say that the people who work for them are not allowed to prescribe under the guise of that organization. As far as I understand, a provider could then prescribe outside their daily work, and that's different and they cannot be penalized.
One thing to add about that might give people pause, providers pause for doing that, is most of us, when we work for large institutions, for example, when I was at UNM, I was covered by UNM's malpractice. Now, if I'm going to go step outside of UNM and prescribe, I better have my own malpractice. Most people don't. And in New Mexico, it is very, very, very expensive to get malpractice insurance. Cost prohibitive for some people.
That's a really good point.
Is MAID actually rare? I mean, seriously, is it just rare? Is this one of those last resort, total law privileges that's just rare?
Good question. Is MAID actually rare? So are you asking, do we see people asking for it rarely? It comes in waves.
Yeah.
There are days where I feel like every single person is asking us for it. And then we have periods of time where we don't get that many. And so actually when we were back in 2021 talking about this law in this state with our particular demographics, we thought it was going to be incredibly rare. Turns out it's way less rare than we thought it was going to be. And that surprised all of us, given in general, the people who access and ask about this tend to be well-educated white people, and that is not the majority of the people in this state. There are exceptions, of course, but no, New Mexico is using it at a rate that is much higher than we thought it would be. That is a Pandora's box, but it surprised us.
So I work with end of life options in Mexico, and we do keep account. Not everyone remembers to report to us, but as of about 2 weeks ago, there have been over 700 ingestions in the state of New Mexico in the 3 years, a couple of months since the law was passed. 3 years.
That's pretty staggering compared to other states. That's staggering. 700 deaths in 3 years compared to other states. The rate of population versus how many people are using, it's high. And the reason that it is both surprising and a little concerning is that New Mexico really has a very low score for access to hospice and palliative care. So we're not doing the standard of care in all of the state, which is hospice. That's the standard end of life care is hospice. Not everybody has access to that, and so they might not have access to the standard, but they do have access to MAID. So that's just something to keep in mind about, usual care. Still have to meet the same criteria, but wouldn't it be nice if we could offer hospice to every New Mexican as the standard of end of life care?
Do you get back to what happens in the process?
We went off on a tangent. Where were we? We were talking about the prescription, the 48-hour. So in New Mexico, we have a very high rate of deaths that are attended by the prescriber. In California, for example, I think it's like 10%. 10% of people who are ingesting MAID have their healthcare people with them. In New Mexico, it's over 90. We do it better.
Yes.
We really do. Our time to death is lower. Our complications are lower. We are really attentive. If we have someone who's going to use MAID, there's a whole list of things that we need to make sure are happening before the medication even shows up at the house. Their guts need to be working. They need to have the power to either drink or we can do it rectally if people can't drink for whatever reason. So that's just an important thing to know that I didn't want to forget to say. Typically once we have chosen a date, we ask people to not have the medications in their home until they are absolutely certain that they're going to use it. And the reason for that is if they don't use it or they die before they can use it, their survivors are on the hook for figuring out how to dispose of this. None of the pharmacies so far, we're trying to figure out how to help families get these lethal, you don't want them in the house, medications out of the house and disposed of in a safe way. That is a big, big, big deal. So we really try to ask people, let's not have the pharmacy deliver until we're sure. The pharmacy delivers the medication in a lockbox that we have the code to. And if for some reason a patient didn't want us to attend the death, then we would help, we would obviously tell them how to get access to the medication. On the day of ingestion, I see your question, but I'm going to finish this and then on the day of ingestion, we need to make sure that people have been fasting for 12 hours. We want an empty stomach. We have to tell people not to eat dairy the day before they ingest, which for me might rule me out. If I can't have my brie, I don't know that I can do it. But no dairy the day before, because it really binds up the gut. We always recommend, you made a good point about sorbet, that people have sorbet in the home. The morphine burns the throat, the amitriptyline burns the esophagus. There's no way around it. You put something really sweet and cold in the mouth, you drink the med, and then you take another bite of sorbet, and that helps the burning. There's no way that we can get around that. These medications are disgusting for a reason. We don't want people just picking them up and drinking them.
Yeah. Now you mentioned rectally if someone can't ingest it this away, would that be an option for someone who could but otherwise doesn't want to go through?
Yeah. Most people will bear the burning. Is rectal an option for people who worry they're not going to be able to keep it down? And it is. Most people would choose to bear the burning over having a rectal tube, but some people really are like, no, I know myself. I know I'm not going to swallow this medication. I'd rather do it this other way.
Yeah.
How long does it last, the burning sensation?
Seconds
to
minutes.
It's initial contact.
Yeah. Less than a minute, would you say? So someone might take a bite of sorbet. We don't even hand over the medication until we make sure all the things have been said, all the sentiments have been shared, all the important things have been done. Because once that medication is in, there will be a coma. The person who takes it will go into a coma within 5 minutes, usually. On average, the deaths take a couple of hours. People develop an abnormal breathing pattern. We counsel on all of that ahead of time so their family members know exactly what to expect. We believe that when people are in comas, they can still hear. So we really counsel people to, be with their loved one in the way they want to be. Don't crack any inappropriate jokes yet, you know? Tell them what you want to say, even if you've already said it. And then, if it is a rectal administration, hospice nurses are amazing. They're the ones who came up with this. We use a Foley catheter tube, a really small tube that we put in rectally, and we use a syringe. And the human who's ingesting must show us of their own power that they intend to push the medications. Some folks who are dying are weak, and they might not actually be able to do it. So they have to show us that they are trying, and then their loved one can help them as long as they show us that they're trying. Same thing with drinking the medication. What if they don't have the ability to use their hands? We can use straws. We can kind of use different ways to get around it, but the human who is ingesting must show us that they are trying to ingest. This is not something that we do for them. I'm gonna pause. There's a lot of questions.
You answered almost every question that I have. Thank you. The one question I have is, remain is with the rectal complication. I would think that there really wouldn't be burning sensation.
With rectal administration, is there burning? There is. And sometimes we can flush with a tiny bit of saline. We don't want to go overboard because we don't want the medicines coming out, but even just a tiny 2 teaspoons worth of saline can help decrease that. So we do that. And we still, interestingly enough, for rectal administration and for oral, we mix it with apple juice. Which I don't know why we do that for rectal, but we do. Apple juice for everybody. It's just 2 ounces. It's a very small volume of medication. So it's not like a huge, 12-ounce smoothie slurry that has to go down. It's just a couple of ounces.
What part of the body does it go to when it goes up there, like the rectum? What part of the organ is the one that makes it go?
It gets absorbed in the intestines. So we need either the stomach or the intestines to absorb the medication. So that's why we're so meticulous about constipation. We need that GI tract empty. We need it empty to be able to absorb the medications and work the quickest. The more stuff that's in there, the less the guts are working, the longer it will take.
I have a question that kind of changes gears, so I don't know if you're done with talking about MAID or not.
Okay.
But the question that I have is what is the status of death doulas in New Mexico? Are they licensed? Are there groups trying to license them? Can you hold yourself out as a death doula without training? What if a volunteer wants to begin holding themselves out as a death doula? What that whole set of issues around who death doulas are and how do you see yourself as a death doula?
Great question. What does the landscape of death doulas look like?
Thank you. Yeah.
Right behind you is Danielle. Are you presenting tomorrow?
Tomorrow is all
about.
Okay.
Will you be
I
here
can show that.
tomorrow?
Okay.
Will you be here?
Yes.
Okay.
Yay.
Death doulas are amazing. We love partnering with them. I don't know all of the answers to your questions, but it sounds like they'll come tomorrow. We feel strongly that it is never bad to have more people loving on the people who are going through this.
Okay. Go back to MAID now.
Okay, I want to acknowledge somebody wanted to hear about alternatives. It's still in the back of my head.
The medications that you give for the MAID, you can customize those according to the patient's wishes, or is it always the same?
You can customize them if you think that those doses might not be strong enough for somebody who is already tolerant to really high doses. We don't really customize otherwise. Do you have a specific example?
No, I just thought you said earlier that you can customize the, maybe I didn't hear it right.
It tends to be the same doses of those 5 medications for every patient. Every once in a while, we might get skittish that they are already on so much morphine or so much benzodiazepine that we might bump those doses, but I would say that's really rare.
That's very rare.
And then just to reiterate about the medicines, the phenobarbital gets absorbed first, puts you in a coma.
2 of the medicines work to stop the heart, 2 of the medicines work to stop the breathing. So that's why there are so many.
I'm gonna dovetail back to the question that Vincent was asking, because I'm not sure I was really clear. So why does the death path actually take about 2 hours as opposed to when we take our dogs to the vets and it's more immediate? What is the justification? Either the physician justification or the legal justification for that duration?
It's not a planned thing. It's that when people are dying, their guts are not healthy.
And dogs are?
Those are injections.
Oh,
That's in an IV, yeah. So we have
that
these
is it.
imperfect, unhealthy guts, and they're gonna do what they're gonna do.
It's all because it's oral.
Yeah.
We don't want it to last long. It's not, we're not like,
8 hours of suffering for you, 12 hours.
want to punish you.
Yeah, no, it's just our imperfect guts.
Okay.
Yep,
Oh,
yep.
Are human bodies bigger than the little animals? That's part of it.
Oh, I mean, maybe.
The bodies are big.
Yeah, I think, I think it's really the IV versus the oral or the rectal. We need a whole entire system to break down these medications. And our systems are sick when we're dying.
Yeah, I hadn't thought of that part, right?
Yeah.
Maybe I'm confused, so then why can't we, if we choose to do that, have the, injection? The law. Is the law?
It's illegal because it's illegal in our entire country.
Yeah.
So that's euthanasia, right? That's Dr. Kevorkian.
That's
Us, the people putting a medicine into you. We are doing it to you to have you die. Yes, peacefully. Yes, maybe at your own wish, but we are doing that to your body. The only thing that's legal in our country is you choosing to do it to your body. I can facilitate that by prescribing it to you, but you have to do it. You have to take it. I can't do it to you.
You can't inject yourself. Correct. No, there's no
Not right
injection.
now. There's no, it's just not available by injection.
So I
Nope.
have
Wow.
another question. So in another country,
Mhm.
how is it by injection?
Yes.
So if you go to Switzerland, it's
Yeah.
done by injection. Switzerland is injection.
Yeah, I'm not sure who does it by injection.
Yeah.
Belgium, Netherlands.
Belgium.
Thank you. There are other places. Yeah, Netherlands is the one that jumps into the pig.
Let's say Canada. Also.
Yeah, Canada's done some interesting things recently, but yeah, different than the United States, for sure.
So Canada would also be injection.
Is Canada doing it that way?
It's the patient's choice.
And they have a residency. They're still working on the legislature, but you need to be, you don't have to be a Canadian, but you have to have resided.
I'm just gonna go this way.
So, and when talking about Europe, other countries, I know that some of them are allowing MAID for, mental health.
Yeah.
Illnesses, and do you see that coming this way eventually? I mean,
So the question is, we've noticed that other countries, Canada's the one I'm aware of, have started allowing medical aid in dying for mental health diagnoses. I think we're probably not close to that in this country, but I am sure there are people out there advocating for it.
There have been some interesting cases in the United States of folks with what's considered end-stage anorexia, which is a slippery, hard to prognosticate situation. But that's really the first of the more mental health based diagnoses. Yeah.
Let's move here. Sorry, we're just gonna make a wave over.
I was curious for the 700 deaths over the past 3 years, like what does that represent as a percentage of prescriptions? Like when you've done the whole process and somebody qualifies, what, I'm assuming not 100% actually follow through, but I'm curious what the percentage is in New Mexico. And is that also being tracked like nationally, like for the other 10 states, just as a comparison?
So the question is, what percentage is that 700 of total prescriptions written? I don't know the answer to that. I don't know if we are tracking it. The statistics across the country tend to be somewhere between 30 and 40% of people don't make use of the prescription. I would say in my personal practice, it's around that, but I don't know I don't know the answer to that. Does anybody else?
I don't know the answer for New Mexico, but I know in Oregon in 2023, 60% of the people who received prescriptions for death with dignity actually utilize them.
So that fits with that 30 to 40% who don't.
Right.
And when I looked for that percentage across the country, that's generally what I saw. But I don't know if it's different here. Yes.
How many people come from out of state to die here because of MAID?
I have an N of one, honestly. I don't know. I don't know that information. And I don't know how we would really track that.
Well, when you do a death certificate, and well, who does the death certificate? So, okay. And that doesn't say.
It's absolutely not on the death certificate.
Okay.
Their place of death is on the death certificate.
Place of death, not a place of residence.
I actually kind of like the ambiguity. I have some in-laws that are coveting our state, so, yeah.
So on the question of people coming from out of state, I don't have numbers, but I can tell you as end of life options, if we have a warm line, we get a lot of calls from Texas and Arizona. And we have a lot of people who come here to use the law. So I don't have statistics. I wish I did. I don't know why we don't track some of these things. But generally, if people come from out of state, they do take the med.
So it sounds like we are getting people from out of state coming here, mostly Texas and Arizona. And if they do go through the effort of moving here, it sounds like they are going through with it.
Because they go through a lot to get. I recently had a client who flew in from Iowa. And it was all she could do to make 2 plane rides to Santa Fe. I picked her up at the airport. So yeah, we support a lot of people.
I'm not sure I got the question answered about the various hospice. If they are corporate, then their location is out of state. And
Sometimes.
So you ask if they're corporate or they're privately owned or.
You could, yeah. So your question is, you want more information on how to tell between the different hospices. And we have sort of our 3 ideas, which is ask your friends and family, your coworkers. Ask them if the physician visits the home. I would bet money that most corporate agencies are not having physicians visit. So that's one way to tell. And the third was, where is their office? Where are their headquarters, right? So there are some, I don't know if there are corporate that is here. No, all out of state. So ask where their headquarters are. If their headquarters are not in New Mexico, in my mind, are they interested in New Mexican community? Do they know what we look like and what our demographics are and what our needs are and what our barriers are and what our patients' families traumas are in this state? And so for us, it's really important to take care of our community in a way where we understand what that community means. And if they don't live here, then they do that. And it doesn't mean that they might not have individual nurses who are fabulous. But that's one way to screen them. Did that answer your question?
There's only you, you're the only one.
No. There's us, there's Roadrunner, there's Interim Hospice, there's Rio Grande Hospice. There's a number of other really tiny ones. A Desert.
ABQ Hospice. ABQ Hospice.
ABQ Hospice.
Yeah.
So there's a number of small locally owned hospices for sure. We are not the only ones.
As I've tried to do something like Google,
Mm-hmm.
which was mentioned, and I was Googling assisted living. Dan was in boondoggle. So Googling may not necessarily find.
We have more 5-star Google
Yeah,
than any hospice in New Mexico right now.
You can go on.
But you're right, that Googling gives you all the sponsor people head to the top and it can be tricky.
Yeah.
I'm gonna head, you haven't asked one for a while.
In response to finding hospices, and maybe it was said earlier, but, just to clarify, do you need a physician to, refer you to a hospice, or can any individual call and say, I want hospice?
Great question. Do you need a physician to refer you to hospice? And the answer is no. You just call them and say, I'm interested, and the hospice should take it from there.
I just wanted to share for those who might be interested in this. There's a foundation called Euthanasia in Switzerland, in which that if you get a diagnosis for dementia, you can document, I am of sound mind in this moment, so that when you are ready, you can go to Switzerland and get MAID for dementia. Pardon?
Dignitas.
Oh, Dignitas, thank you.
Yeah, she was sharing information about Dignitas, where if you're diagnosed with dementia, you can put in writing your wishes. And then when it's time and you can no longer state your wishes, that can be proof. That is not true here in New Mexico, but in Switzerland. I want to be mindful of time. It's 10:30. You've not asked a question before, so let's answer your question, and then I want to talk about alternatives, and then we'll go.
Do you have any private, hospices taking on Santa?
I'm sorry?
In Santa Fe. Do you have any hospices that are locally owned in Santa Fe?
Santa Fe? Red Willow, we think just expanded to Santa Fe.
Yep, from Taos to Santa Fe.
Taos has a couple of great ones.
That's the one I know of off the top of my head. Roadrunner's also in
Oh,
Santa
yeah.
Fe.
Roadrunner has expanded to Santa Fe.
Is there a state association of hospices?
Is there a state association of hospices? New Mexico and Texas are combined. And there's a hospice care situation online. We're brand new, we're baby, so we're not on those yet, but we have started getting our surveys back. There were people rate us, so we'll be on there soon, but that's another way to look at hospices side by side. So I very quickly want to go through alternatives to medical aid in dying, because I know we're at time, but I don't want to leave that. I think it's really important. We document every time we evaluate somebody for medical aid in dying that we talked about alternatives. So the alternatives to medical aid in dying are excellent continuation of hospice care, right? Really, really hands-on interdisciplinary care of the human and their people. That's what we've always done. I think that is a great alternative for people who don't maybe meet criteria. Like we said, you can be on hospice, but maybe not quite meet that bar. You could do voluntary cessation of eating and drinking. People heard of that?
Much easier said than done.
Yes.
It's a hard road. There are a lot of resources for people who want to go through that. If somebody's not on hospice, they want to go through that, they would then become eligible for hospice partway through. It's called conferred terminality. It's tricky, but we should talk about it. It does give people control, but it is hard. It comes with symptoms, hunger, thirst, hallucinations, delirium, things like that. It's hard to stick to. Those are the alternatives.
Symptom-driven care.
Yeah, standard of care, symptom-driven care. Chasey.
Oh, thank you.
Yes, palliative sedation. That is an alternative. We don't use it very often. Palliative sedation is where you basically sedate somebody to get them out of their suffering, and the consequence of making them asleep is that they don't eat and drink and they die. I've only done it a handful of times, and it has only been when every single other thing has failed. We have done excellent escalation of medications. We've switched to IV medications. We have added others. We have done everything, and we just can't keep up with or help that suffering. That's in my experience.
That is almost exclusively used for terminal agitation or terminal delirium, which can be a bear to treat, or horrific existential distress at the end of life that no pill is going to fix.
So the question was, can you go to a hotel if you're from out of state? We've had bad luck with that. The authorities get involved. The hotel may or may not know ahead of time. It's a mess. There are assisted living facilities who will rent a bed. There are volunteers out there who will rent or donate their casita for a day or two to go through this. So that's an option. End of life options. New Mexico has a lead on some of that. There's probably more in the community that we don't know. But I wouldn't do a hotel. Okay, we are over time. Anything that feels incredibly important, or did we do okay?